right. Welcome back to Just Hard, real nurses, real talk, real life, because nursing is just hard.
And today, we're going to talk about something that every nursing student memorizes, but doesn't always truly understand.
IV fluids, what they are, when to use them, and what in the world isotonic, hypotonic, and hypertonic actually mean at the bedside.
No fluff, no trick questions, just real life nursing.
Yeah, let's start with the big picture. Before we start naming bags of fluid, we have to understand one thing. IV fluids shift water. That's it. That's the job.
And how that water shifts depends on the fluid's tonicity, meaning how concentrated it is compared to our blood's plasma.
Yeah.
Normal serum osmolality is about 275 to 295. Didn't complete my thought there. If a fluid matches that, it's isotonic, lower, hypotonic, higher, hypertonic.
And here's the key. Water always moves toward higher solute concentration. That's osmosis. So let's break them down. So let's start with isotonic fluid. Isotonic means the same concentration as plasma. No major fluids shift into or out of the cells. The fluid stays in the extracellular space, mostly intravascular.
Translation? These fluids expand volume. They're your go-to when someone is hypotensive, dehydrated, bleeding, septic. Most common isotonic fluids are going to be 0.9 saline or normal saline. Lactated ringers, D5W. D5W is a little different, though, so it's isotonic in the bag, but physiologically, it's going to behave differently once metabolized because once that sugar's gone from the water, we're just left with straight water.
Yeah, that's tricky. This is a tricky one. I get it. So when do we hang isotonic fluids? So we hang isotonic fluids when we need volume. So an example of when we would need volume is a hypovolemia, like dehydration, hypotension, sepsis, because our fluid is leaking out of the cells, out of the blood vessels, GI losses, so if we're vomiting, have diarrhea, burns. In the initial resuscitation phase, IV fluid resuscitation is key, and in blood loss.
So these are going to be your fill the tank fluids.
Yeah. So here's a caution. Because they expand volume, they can cause fluid overload. So we want to watch for crackles, which means fluids, increased blood pressure, jugular venous distension, or JVD, edema, shortness of breath, especially in a patient with heart failure where the pump doesn't pump very well, renal failure where the filter doesn't filter and they don't excrete very well, and older adults who are super sensitive to fluid shifts.
And then now we're going to transition to hypotonic fluids. So hypotonic means lower solute concentration than plasma. So what happens, Lisa?
Well, water moves into the cells. The cells swell. So the most common hypotonic fluids are half normal saline, 0.45% normal saline, D5 half normal saline, and D5W. So this is after the dextrose is metabolized, so then the D5W. So when do we hang hypotonic fluids? These are used for cellular dehydration, hypernatremia, so high sodium levels, DKA, so after the initial isotonic resuscitation, then we want to hang hypotonic fluids, and then maintenance fluid.
Right, so we're going to think cells are dry, so we need to rehydrate those cells, right?
Yeah, so here's another caution. So in the hypotonic fluids, because fluids move into the cells, we can cause cerebral edema, increased intracranial pressure, and hypotension. So avoid hypotonic fluids in a patient with a stroke, a head injury, brain swelling, or severe burns in the early phases specifically.
Now to hypertonic fluids. So hypertonic means higher solute concentration than plasma. So where does water go, Lisa?
So water goes out of the cells and into the bloodstream. So the cells actually shrink. The most common hypertonic fluids are 3% normal saline, D5 normal saline, D10 water, and D5LR or D5 with lactated ringers. So when do we hang these hypertonic fluids? These are serious fluids. We use them for severe hyponatremia, low sodium levels, cerebral edema, so this pulls the fluid out of the brain cells to decrease that edema, and sometimes hypovolemia with hyponatremia.
So this is going to be ICU level thinking, right? So a little bit deeper than maybe what we kind of getting exposed to at level 3 here, but still need to know those concepts, and down the road, it's just going to build off each other, right?
Exactly, yeah. So hypertonic fluids can cause fluid overload, pulmonary edema, rapid sodium shifts, and osmotic demyelination if it's corrected too fast. And so we're going to see some neurologic changes if we give it too fast. So these require close monitoring. Oftentimes these patients will have a central line, and we need to do frequent sodium check. Hey, Rob, it's time for an unsponsored commercial.
So, Tennessee movers, so where do you want the water to go? So, are you a nursing student staring at the IV fluid cabinet thinking, saline one?
I don't know. They all look clear. They're all wet. They're all drip.
Then you need tonicity movers.
Okay, I'm already laughing.
Yeah, so, well, it's going to get better here, Lisa. So, I'm ISO. I'm balanced. I'm stable. I don't cause drama.
Oh, you're 0.9% normal saline energy.
Exactly. I stay in the extracellular space. I expand volume. Hypotension, I got you. Sepsis, I'm your guy. Bleeding, let's fill that tank.
So you're not moving into cells?
Nope, I stay where I am put.
Students, isotonic equals stays in the space. Hi, I'm hypo. I hydrate cells.
Why do I picture you watering houseplants?
Because I move water into cells. Hypernatremia, cells are dry, maintenance fluid, I go inside.
So you make cells swell?
Exactly.
Which means that's going to be not so great for some of our brain injuries, right?
Correct. We don't swell brains.
We do not swell brains.
Haha.
Okay, so move over. I'm hyper.
Oh no, you're 3% saline, aren't you?
Yes, ma'am. I pull water out of cells. Severe hyponatremia, cerebral edema. I shrink things.
Which sounds powerful.
It's because I am. Monitor sodium, monitor lungs. This is not just a hang it and walk away situation. I got to be taken seriously.
Okay,
you will
pause.
take me seriously.
Let's make this simple. Before you spike any bag, ask yourself,
where do I want the water to go?
Inside the cells, hypotonic.
Stay in the bloodstream, isotonic.
Pull fluids out of the cells, hypertonic. Same equals stays.
Low equals goes in.
High equals pulls out. Now let's win. Because here's the truth. IV fluids are not just fluids. They are fluid-shifting medications.
Hang the wrong one, and the water will absolutely move, just maybe not where you meant it to.
And that's when nursing gets just hard.
Go
ahead.
Tonicity movers.
Putting water where you actually meant for it to go.
Because nursing is just hard.
And you can do hard things. That's our unsponsored commercial for tonicity movers. All right, let's go into a quick bedside memory trick. Here's the easiest way to remember this. Isotonic equals stays in the space. Hypotonic equals hydrates the cells. And hypertonic equals shrinks the cells.
And if you're unsure, ask yourself, where do I want the water to go?
All right, so let's apply some real nurse clinical thinking. Let's make this real. Your septic patient is hypotensive. What do you hang?
Isotonic. So we're looking at normal saline or lactated ringers or LR. We need some volume expansion.
Your DKA patient, after initial bolus, sodium is high and cells are dehydrated.
Now we may need to make that switch to hypotonic.
Your patient with sodium of 118 and confusion.
We're going to carefully, and I emphasize carefully,
no doubt,
administer hypertonic saline.
So in closing, IV fluids are not just maintenance. They are powerful medications.
Every bag you spike is going to make fluid move somewhere. You need to know where.
Because nursing is just hard.
But understanding your fluids, that's just going to make it a little less hard.
Thanks for tuning in. We'll tune in next time for our next episode of Just Hard.
See you all next time.